Hello, good evening, good afternoon, good morning, good day, wherever you are in the world, and welcome to the Black Belt Academy of Surgical Skills. My name is David Wigan. I'm a professor in the Medical Education Research and Development Unit in the Faculty of Medicine at the University of Malaya, here coming to you live from Kuala Lumpur. I'm a retired cardiac surgeon. I'm passionate about surgical training and the learning of basic skills. And this has been really spurred on because of my interest in continuing journey in the martial arts. My fellow senseis, Chris and Sile, join us this evening for discussion later, and their valuable contributions are really enriching this program we have at IACO. And it's thanks to IACO and Dr. Abhijita in New Delhi that we are able to reach countries across the globe and come to you live. All these sessions are actually uploaded onto our YouTube channel for catch-up, and we do commend, if you've missed any, to look at those. This is supposed to be an interactive session, and it's ready for you to ask questions. The thing is, it's live, it's not massaged, there are no cuts, and you'll see it in real time. And I'll share with you the tips and tricks that I've learned over the many years of surgery, 10 of general and 22 of cardiac. So, since we last spoke, I'm delighted to say that our work with fellow senseis, Sujaya and Chris Caddy, together with Nithya in the Social Epidemiology Department of the faculty, and two medical students, Akash and Vinesh, we have submitted a paper that is looked at the scoring of stitching on the banana that we have demonstrated as a black belt skill. The five of us scored 94 bananas, and we have inter-class correlation of 0.97. We've submitted this for publication, and I'm meeting a professor of mathematics and computer science on Wednesday because I have a vision to translate this into a handheld app so it enables you to document your journey and progress in surgery. I think that'll be a first. Well, this evening is about surgical dissection. And we're going to combine the lessons that we've had in the past couple of weeks of the knife and the scissors and show how we bring this all together in the principles of surgical dissection. Now, the purpose of surgical dissection is to expose anatomical structures and to safeguard structural and physiologic integrity. The goal is to maintain correct orientation and direction of dissection with minimal bleeding. Minimal bleeding means we're able to see clearly and allows full visualization of the tissues and relevant structures. Excessive bleeding may indeed mean we are in the wrong plane altogether. And we have to be mindful of that as we progress. So, what we're doing in dissection is finding those avascular visceral connective tissue planes. And it allows for identifications of structures by sight and palpation. And the ones we must look out for are the nerves, the vessels, arteries, and veins. But during the course of this process, we must maintain a degree of flexibility and reassess our dissection site constantly and switch between using the knife and the scissors and other instruments that may be appropriate. And I'll demonstrate some of those to you this evening. You see, this is all because we started as an embryological disc of 3 layers, an ectoderm, mesoderm, and endoderm, and all connective tissue derives from the mesoderm and consists of collagen and elastic tissues, fibroblasts, and fatty cells, all within a jelly matrix. And this supports the organs and fills the spaces between them. It also gives rise to the endocrine glands, heart muscle, kidney, and urogenital system. The strengthening mesoderm gives rise to the blood vessels that supply the organs developing in the endoderm. In other words, the gut, the liver, pancreas, and respiratory system. The neural system and the peripheral nerves arrive from the ectoderm and likewise pass through the mesoderm and thus are often found in the tissue planes. Nerves are easily identified because they're white in discrete cords. But it's all this folding and all the branching and twisting during embryological development that gives rise to what we know as surgical planes. And these are usually bloodless, except for around our exocrine glands. And our endocrine glands, because of their function, secrete hormones into the bloodstream. So they're surrounded by a myriad of small veins around the adrenal and the thyroid. And because veins do not have a muscular layer, they do not dithymy, and veins are usually very variable in their position, and you need to be aware and on the lookout for them, but identify them and ligate them at all times, because they certainly do not dithymy. And when they start bleeding, they ooze and ooze and ooze, and it's difficult to control, particularly big veins. So surgery is best affected by understanding the surgical planes of dissection. For example, how many of you recognize scalpel fascia when opening an abdomen or chest? You probably don't, because now you're using laparoscopic surgery. But scalpel fascia is a membranous layer that covers the lower thoracic and anterior abdominal wall, anterior to the mid-axillary lines. And here, the fibrous septa of subcutaneous tissue are condensed beneath the fat into a thin and very strong membrane. And it's that membrane that you need to close when closing a large edematous adipose abdomen. Our muscles themselves are defined and separated by connective tissue. In fact, every area of the body can be described in surgical perspective from tissue planes. And that's why it's important to be familiar with the tissue planes. And what's interesting, we don't teach these planes that often, but an expert surgeon recognizes them, develops them, and you look and you say, oh, how did you find that? And you do need to ask. So dissection not only follows the planes, but as I've already referred to, it follows the arterial blood supply, particularly into solid organs. Because the blood vessels developing from the splenic mesenchyme invaginate into the developing organs and carry with them these layers. And these layers on the vessel itself are, in fact, bloodless. We see that, certainly, taking the long saphenous vein in cardiac surgery, dissecting out that layer, as demonstrated last week with the Mackintosh scissors over the sausage, cleans the vessel up and allows for accurate ligation. And we'll be talking about ligation in the forthcoming weeks. So all of this also needs to be done with a lightness of touch. And that is where we've stressed the handling and the application of your fingers to the instrument. In fact, some of the dissection sometimes is best done gently with your fingers because you can feel the nuances between an adhesion and soft tissue, perhaps, remembering that adhesions are stronger than soft tissue. And if you try and rip it off, you would tear the tissue underneath, the liver, the lung, the epicardium, with air leaks and significant bleeding. So the tissue plane is defined as a potential space separating structures, such as organs, muscles, nerves, and blood vessels. And it frequently, but not exclusively, contains loose areolar tissue, and they easily separated with a combination of sharp and blunt dissection. It's important to remember that the finer tissues contrast to the deep connective tissues that form fascial boundaries, as for example, the prevertebral fascia. And this is an important distinction because local anesthetics will not diffuse across fascial boundaries. So I did ask you about, would you prefer to have a laparoscopic hernia repair under general anesthetic or local anesthetic hernia repair open? It's a good question, that, because if I reflect on the complications of general anesthetic and potential complications of insufflation of carbon dioxide into the peritoneum, I think I would prefer a local anesthetic hernia repair done by an expert surgeon who is gifted dissecting the tissues. So we got to remember that all the tissue planes provide a conduit for nerves and blood vessels, lymphatics, and just think of the femoral canal or the carotid sheath. Just to point out that the femoral vein and the jugular vein do not actually sit in a sheath. They can't, because if they were constricted by an external sheath, they could not expand to help with cardiac return on exercise. So lateral to any big vein is a space: femoral vein, jugular vein, and others. So proper identification enables you to safely progress and isolate anatomical structures. But these planes are often convoluted and require very good visual, spatial, and tactile acuity. For example, the white lines of taut on the lateral borders of the ascending and descending colon are avascular reflections of the posterior parietal peritoneum and are critical for identifying the proper plane for hemicolectomy, and also being aware of the ureter at the back, which is the only white structure at the back. If you gently touch it with your forceps, and I say gently because we've pointed out that forceps cause damage, it has a vermiform reaction. It looks like a wriggling worm. There's nothing else in the abdomen that does that. On tissue planes, in the abdomen, if you come across a viscus that you think is strange, it's usually the duodenum. And in cardiac surgery, the left atrium is often referred to as the duodenum of the pericardium as well, because it can appear in odd sort of places. So another good example is an extraperitoneal hernia repair. Depends on the ability to dissect the plane between the preperitoneal space, which lies posterior to the rectus sheath, and the peritoneum. And I remember one of my first emergency femoral hernia repairs as an SHO. It was a lovely femoral hernia, and I thought I'd do a preperitoneal approach, and I had the anatomical textbook on the diathermy machine, and I was really enjoying my dissection, looking at the book, looking at the wound, and seeing the planes just open up, and indeed found a small bowel Richter hernia in the femoral canal that required resection, which I went on and did. I told the boss the next day, and he said, "You did what?" I said, "Yes." He said, "Oh, this was in those days where you got on and did it." Fortunately, the patient was well, but I thoroughly enjoyed that operation and remember it. So another important element of a plane is between the pelvic parietal fascia and the mesorectal fascia, commonly referred to by colorectal surgeons as the holy plane. And certainly it's deep down in the pelvis, but those people into laparoscopic surgery, that plane now becomes a lot more visible. And it enables an en-bloc resection of the mesorectum with all the nodes while sparing the sacral vessels and the hypergastric nerves. An improvement in the understanding of this reflection and anatomy has led to development and improvement of techniques and a substantially better low rectal cancer recurrence rates following surgery. In pulmonary segmentectomy, the procedure is minimized by the degree of parenchymal dissection, which again means identifying the pulmonary artery going in there, usually followed by the bronchus, but also can be accomplished by clamping off a segmental bronchus and gently inflating and looking at the rest of the lung that has been blown up. For those of you who do abdominal surgery, Callow's triangle for the identification of the cystic and bile duct and the lateral and cephalic traction being applied to the gallbladder is absolutely important to identify that cystic duct and not mistake it for the bile duct. But of course, all this now becomes rather difficult in acute or chronically inflamed tissue where it might be edematous or scarred and distort the appearance or location of important anatomical landmarks and bleed, adding to the problem. Also, the presence of pus or foul odors may signify necrosis or bad tissue. And there is a story of somebody doing a vaginal hysterectomy, and an attendant in theater broke wind silently, but the smell was obvious. And the surgeon, picking up the colorectal smell, thought he had opened the bowel and then proceeded to a hysterectomy. I don't know if it's true or not, but the attendant did not own up for that little mishap. So surgical resection of a neoplasm requires several techniques as well. First of all, you need to plan, review, and modern CT scans and MRI together with 3D printing will actually help you do that with HoloLens as well. And will determine the spread and candidacy for surgery. I was particularly impressed that recently people have removed a basal skull tumor going through the eye orbit. So no incision, went through the eye orbit without any damage to the eye nerves and resected that. So as we begin to learn more about tissue planes, our access is improving, particularly with micro-instruments. If the tumor is well encapsulated and benign, wide margins are not necessary. However, it's important to consider that some malignant tumors may well appear to be well encapsulated, but there's a lot of microvascular invasion and microscopic invasion. And this is particularly true of glioblastomas multiforme, and it would be impossible to delineate from normal healthy tissue. And this is why the neurosurgeons wake the patient up during the operation and have them perform music with violin or sing and speak as they actually try and remove tumors without any neurological deficit. So your anatomy is fundamental to this. And I think of the phrenic nerve on scalenus anterior, keeping below the axillary vein when I'm dissecting out nodes on a breast cancer and a mastectomy, the nerve on the psoas being the genitourinary nerve, gives sensation to the thigh and scrotum, the thoracodorsal nerve on the thoracodorsal nerve on latissimus dorsi that enters 1 centimeter before the edge of the latissimus dorsi, and of course I mentioned the ureter. So there are a couple of fundamental rules with dissection. One, you start where the anatomy is normal, all right? And once you find the normal planes, you work from normal to abnormal. And it doesn't matter whether it's trauma or elective reconstruction. The surgeon must always find normal anatomical structures and planes and walk towards them. The corollary is, once you identify the plane, stay in the plane. Don't jump to another plane, because that is where things go wrong. And the second most important is the traction and counter-traction that is necessary to proceed the operation. So it's difficult to do a dissection without an assistant. But remember, there are lots of tips and tricks for you to actually apply traction and counter-traction. Remember, though, the forceps does cause damage. And the longer tissue planes may be held with a swab. Otherwise, You could use a couple of sutures or a couple of forceps. And the counter-traction, again, applying the swab. So all the time, you're looking for traction, counter-traction. And this is where having a good assistant is very important. So the scissors are best used for small areas, and it's a nibble. And on wider areas, it's a blade. But that's down to personal preference. More senior surgeons, to be honest, would probably be more comfortable using a blade. And the important thing is that sharp dissection is clean dissection. Remember that adhesions will always have more tensile strength than anything else, and they do need to be cut rather than swept away. Is it a scissor? Is it a scalpel? It depends on the anatomy and your personal preference. But as said, a good assistant, as one orthopedic surgeon said, I'd never be as good a surgeon as you are because I give you better help than you give me. So a good assistant can actually make an operation to a large extent. And this is part of the learning to operate as well, is learning how to use your assistant and the people around you to maintain that traction. And the most important role of the surgeon is to keep attention on the wound. So we've discussed all this. We've used the knife, we've used scissors, but of course there's splitting, there's finger fraction. Sometimes we rub it. There's peeling it backwards as well. In water jet has been used, particularly with liver resections, hybrid dissections. Certainly, I've seen my colleagues use that for endarterectomies of coronary vessels. And there's electrocautery. But as you pointed out, with auto electrocautery, there's a transfer of energy and foregoration of tissues. So hence, the harmonic scalpel is perhaps a very good alternative. So let's get on with our operation now, and I'll take you over. And the thing is, with all things, we start with what we can find in the supermarket. I am going to start with an incision. Remember, the 22 blade is held in the sagittal plane between my thumb and the side of my middle finger. I place my index finger down for proprioception and to maintain the pressure. The incision is feeling it through, maintaining traction. As you see, my fingers are maintaining a traction on the tissue. And what I'm trying to do is cut the skin without cutting the flesh underneath, keeping the blade perpendicular to the tissues all the way. And as we said before, that all comes down to feel. Now I've got a large surface area here. I am going to ask my assistant, who's going to be helping me from the opposite side of the table. He's got long arms, it's my son, but he is going to hold this up. Take that one and that one, and hold those two edges up. So if you take that and that, so, and I apply counter traction this side. Now it's a wide surface, so if you lift it up high, I can use a swab on this area, and I can apply traction down. Now, what we didn't cover before when dissecting off a layer is how to dissect off a plane. So I'm going to keep the blade parallel to this, and I'm not cutting into the plane here. And the movement I'm going to be using is a bit like a brushing the knife against that surface as a brush. And as I do that, I hope you'll appreciate that this plane will develop, and I can use the swab as counter traction all the time. And I'm looking out and being aware for any resistance and I will not feel resistance. If you follow down there, please, just here. I will not feel any resistance if I'm holding this blade very tightly. It would not. Okay, come follow me down here. Just keep coming around. Come down, bring to that, please. Thank you. Lift it up. Very good. And this is part of understanding how, and could you perhaps hold it further down, just there, and there, and there. So we can, how you're applying and reapplying the forceps and your traction at all times. Come down here. So a good assistant would be doing this intuitively. Come follow my knife as it comes around, as I dissecting this over a wide plane. I'm not focusing on a small area at all. I'm using my knife over a wide plane. So could you keep that top there, the side? Hold that, please. Thank you. And it's a very effective way of taking off. There you go. Let's come down here, taking off the skin. I can likewise hold it off with my forceps. And you can see this loose areolar tissue here, typical of. And you see, if I start cutting into it like that, we cut into the flesh, which we don't want to do. So I'm just going to zoom in a little bit closer. So when we come to muscle, the last thing we want to do is cut muscle, right? And if you got to go through muscle, the best thing to do is to split the muscle. So look at the fibers. I'm going to cut the muscle along the fibers. And all being well, I'm using fingers here, but sometimes I will get the fingers out. Could you hold that side, please? Help. There you go, and through that muscle there. There's another fascial layer, you see. So I split that muscle. And at the present moment, I'm fairly confident that I'm not going to see the blood vessel. There's a vein there, with another muscle coming up here. Now, I don't know the anatomy. That's a fascial layer, dense fibrotic tissue, and that's the layer that you stitch back together when closing muscles. We can split this muscle as well. And all this time, I'm actually using sharp dissection with a knife. Now, there, we've got all that there. I'm going to now swap to using BBASS scissors because I've got this structure that's come up here. And I'm not sure what it is, so I'm going to tease it out a little bit. I think, to be honest, there's a bit of loose areolar tissue, but you can see underneath there, I've got a vein. Is that all there? A nerve there. And down here to just hold that up there. And now down to the femoral canal on this. And I'm opening my scissors up along the plane, so parallel to the vessels. There's the nerve, there's the vein, you see. Now, another technique for dissection, and I'll go in a bit further so you can see another technique you can use for dissection is you can use a pledget, but I've got a cotton bud here. You see, I'm very cotton bud. I can gently brush off the loose alveolar tissue with a cotton bud. Okay. And if that would be a little pledget on a Roberts, which is a good use for one dissection. Here we got it's a vein. That's a vein as well. You can see it's purple, white cord-like structure down the back here. Okay, so I'm not going to be careful with the nerve. And if I'm going to be operating on that, what I would do is I would not actually hold the nerve itself, but I might actually try to dissect it off that vein, because what I want to do is hold that gently out the way. When you've got it gently out the way, one of the things you can do with pressure structures like a nerve is put a rubber sling around it. Right, this is a very broad sling, so I'll use a bit of elastic band. But I can hold that out the way, and if that's when I've colored, they're different colored rubber shots, not rubber shots, elastics, yellow and red, etc. You can actually tie off vessels, isolate vessels of arteries and veins, and color code them, to be honest, in your dissection. So now I know that's the nerve there, and I've got it safely out the way. See that? And now I've got, I think that is the vein there. It's got branches, little branch there. You can see that little branch there. I can use my scissors underneath there. And that is a small branch that might actually bleed lots. And that's the size of the vessel that you might find around an exercise gland. So I tried this earlier. It's a little advanced trick that I said I would show you for passing a suture. You don't necessarily have to pass the suture underneath. I've got my scissors underneath. It's going to work for me. I'm not going to try too hard, but I wanted to show that it is possible. To catch. There you go. To catch the suture with my scissors. So I don't have to get another instrument out. I just get my hand on there. Move your forceps, please. So do that. And again, I can use a tie to provide traction as well. So I'll put a rubber shot in there. And in doing so, I have now enabled better exposure at the other end of that vessel. And you can see I wanted to clean off all connective tissue on that. There you go. I don't need a forceps. And it's always best to tie vessels off, flush and clean. We'll come to thing not tying. In 2 weeks' time. So once that's tied off, then you can actually cut the vessel. Do not continue to pull it, because your pull will suture off. But that was a way of demonstrating how to isolate the vein. This is the artery this side, I think. And we can explore it coming down here. And again, the scissors, I'm using the scissors to gently open the plane, remove, take out. And because I'm in a small spot now, I am using my scissors to nibble and identify and follow this further down. So I'm swapping between forceps and knife accordingly. So if you look at those two, you can tell me if I'll just put some more light on there perhaps, and maybe zoom down a little bit further. And you can see yourself, there's one that's purple there, there's one that's pink, yeah? So the pink one there is the artery, purple one is the vein, and the white cord-like structure is the nerve. And that is how you will identify your vessels and structures. Now, when dissecting out arteries, particularly with peripheral vascular disease, you don't want to be cutting off arteries in somebody who's got an ischemic leg because they need as many collaterals as possible. So with a slightly thicker tie, what one can do is very simply pass a ligature around like that. And there you go. You're holding that off to the side, including that branch. And with all vascular surgery, you control the vessel above and you control the vessel below. So if I now wanted to actually open up this femoral artery, all right, which is there, I wanted to open up the femoral artery, I'm not going to get any bleeding from the side branch because I've got a suture around it. I haven't tied it off because the reason I'd be opening this femoral artery in vascular surgery is to do an endarterectomy or a bypass graft. And then I want to afterwards take the ligature off and restore the blood supply through the side branch. What you can see here is a good example of a tissue plane and the vessels beautifully coming through the various tissue planes. And this is, no matter where you are, you'll find a tissue plane. And once you're in the tissue plane, to be honest, I find this surgery fantastic. So again, I'm using a little pledget. I'm using a cotton bud here because there's a bit of a few veins, and I'm trying to identify there's a vein running deeper there. I think that's a muscle, a tendon, that's not a nerve. My nerve, I'm always happy is out the way because I've got my sling on it, and I want to chase this down further. And you can see there, blunt dissection with that is going down all the way. Wow, there you go. Didn't have to force that. That is going all the way down that plane, that cotton bud, and it's down there in the leg now. And I'm going to actually, let's take this bit of muscle off, shall we? To aid our dissection. See how far we can go. That's up to the capsule of the joint. Now I'm going to get this, I'm actually on a capsule of a joint there. That is a tendon. You can see that is thick fibrous tendon, insertion of a tendon. And that you can see is not too dissimilar to a nerve, isn't it? But you can see it's white and thicker. I'm going to cut that tendon because I'm wanting to take this off. So that's to expose it further for you. So I welcome any questions from anybody at the present moment in time. If you've got any questions, please ask. Otherwise, you can see that I'm actually starting to really enjoy myself, and I'll end up going down a rabbit hole here in my dissection. So if you're doing an orthopedic operation, there we go, we're into joint, we're into capsule, or the joint, thick fibers, you can hear the tissue. And now we're actually into the joint capsule itself. And that's a good example of a tendon. There you go. There's another tendon, thick and fibrous as well. But of course, in orthopedic surgery, you'll be joining these back up together, or separating, or retracting. And with surgery as well, we have got numerous types of retractors. And I'm certainly going to invest in a couple of retractors to actually make some of this easier. But there you go, all the way to the top. Vein, artery, vein, artery, nerve, vein, artery, nerve, and it's disappearing down into the leg here, into another fascial space. And you see the fascial spaces when you find, look, it's all the way down the leg, okay? Another fascial plane. When you find the planes, there you go, all the way down. There's my scissors. Come out. You see my scissors right down here and the fascial plane. So surgery, and the beauty about surgery, is actually finding these planes. And certainly I can see with laparoscopic surgery, deep dark holes, it is actually very nice to visualize and see the planes. However, I am concerned at the amount of fulguration of diathermy that is actually happening at the present moment in these operations. Because all of it looks like a barbecue at the end of it, to be honest. It's a rather crude way of dissecting when you've got such beautiful things as a knife and scissors. You see, I'm now using my scissors as a probe to feel my way through. There's the nerve there. See that? That's a nerve. Well, that's nerve. That's a continuation of the nerve there. The nerve there, and that's going further down the leg as well. I could spend all evening doing this. And there you go. I'm just going to take this ligature off here because let's say, and there I've not sacrificed that much. So slings, ligatures, retraction, swabs, peanuts, or pledgets, and roberts are all fantastic tools. And it's almost automatic what I'm doing. Because good dissection is an art that can only be practiced when you understand the anatomy. It does require patience and persistence and a lightness of touch with a proper use of the forceps, the scissors, and the knife. And you have to think about the feel of the blade and the scissors. And it's that lightness of touch that affords the necessary proprioception and enables you to actually feel the tissues. And it's the difference between good surgery being a hewer of flesh or a work of an artist. So dissection is performed millimeter by millimeter in some cases. Up here, I was able to sweep all that off very easily. But gradual, deliberate, controlled movements are essential for thinning out connective tissues and revealing vascular bundles that, as you can see, run between all these tissue planes. Okay, that's probably a branch, could be a branch of the nerve. I can tease it off sometimes, and I can feel that's a bit yellow. That's going into a bit of loose areolar tissue there. That is not a vessel. See, that was loose areolar tissue there. So there you go. And that's down, and there's my cotton bud going down there, and there's the vein and artery going down. There's the nerve. I think that is actually, no, you can see there's a tendon. See that? That's a good contrast. On one side, that's a nerve there, And there, you can see that's a tendon. The tendon actually feels, if I gently hold the scissors, you can feel that actually bowstrings are slightly thicker. The nerve is thinner, and you can feel the difference. But when you look at it, those two look much the same. That's the nerve, that's the tendon. That's the artery, that's the vein, that's the nerve. Those are the tissue planes. And we can continue to explore. Once we get into finding these tissue planes, we could probably end up through the other side of this leg, all the way down here. And that's loose area of tissue. I can cut that. And I'm almost through to the other side. That's another muscle layer there. And of course, you would know, there you go, I'm through to the other side. So there you go, we've got all these muscles, 1, 2, and of course, if you're operating on the limb, you'll be able to name all the muscles, but I haven't cut any of them, not at all. I split this muscle at the top. And there you have it. I'm going to call it there. I'm going to thank my wonderful assistant, my son, who has actually kindly and expertly assisted me. And you can see it makes a fantastic difference to have the traction in counter traction. And it's a synchronized, purposeful movement of the hands and forceps moving. So that's where the orthopedic surgeon saying to his resident that, you know, I'll never be as good as you are because you're not as good as me as an assistant almost. And a good assistant can actually make enormous amount of difference. And I've done this operation, so to speak, with my son previously, and used my forceps to point, hold, retract, and say, don't cut that, move that, cut that, do this, a little bit there. And together we progress the operation all the way through and dissect out as we've done. I've shown you what a vein looks like, an artery looks like, a nerve looks like, shown you the tissue planes, shown you how to separate the tissues, split the muscles, use your blade like a brush, which is the second aspect of holding the blade as well. And would like to invite my fellow sensei, Chris Cuddy at Sealey, to join me in conversation and make observation and comments, please.
Well, my first observation is of Alistair, and to thank him for assisting you, because
Absolutely.
you made that look much easier than any previous attempt at it.
Indeed.
So it's a lot of it is in the assistance and the assistant developing the plane for you and putting tension on the tissues so that it makes it easier for the surgeon.
Correct.
So it was a wonderful demonstration of how to use your assistant to make the operation look easy.
And I think that's one element actually that we don't really teach in surgery, but it's a bit like driving. You can't really learn to use your system until you've learned to use the instruments yourself. Because the next step on top of that is using and being aware of the other people and hands and instruments around you to help you with the process. So it's like conducting an orchestra, really. You've got first assistant, second assistant, etc. And what I found with doing an aortic valve, for example, I could put an aortic valve in 24 minutes. And people say, gosh, that's quick. I said, no, I'm not wasting any time, because the first assistant, second assistant, the scrub nurse and me were rehearsed on the needle pickup and the orientations. So literally I was just doing this. So the diastolic interval, as we've talked before, of setup was rehearsed and practiced with everybody, such that we could just move our hands together and voila.
The other observation was your use of the cotton bud. So different surgeons will use peanuts, they will use various other additions to help them sweep tissues away.
Yes.
Good use of
my low fidelity model at home. You see?
Yeah.
Low fidelity at home.
So in theatre, we tend to use silastic sloops
Yep,
around
that's where
vessels.
my rubber band. Yeah,
Yeah. So, but you have to be very careful with them that you don't yank on them.
correct.
So putting a rubber shod instrument onto it, everybody in theatre needs to be aware where the rubber shod is and don't suddenly lift it up because you can do a lot of damage with that.
Well, there's rubber sloops actually color coded, aren't they? The yellow and red. So you can
Yeah.
point out when the yellow and red, you leave, if you notice, I didn't put it on traction. I just
Yeah.
put it off to the side. You said if you put it on traction, it would cause a neuropraxia. But if you've got it labeled red, etc., again, tell your staff don't touch that or pick that up. But it's a useful way of moving things around. But again, it's communicating with the rest of the staff as well, isn't it?
Apologies, I'm going to have to dash, so I will speak to you later. Thanks, bye.
Okay. Prof. Seeley, any observations?
Hello, Prof. Yeah.
Hi.
Can you hear me? Yeah.
Yes, thank you very much.
Yeah. Thank you very much, Prof. It is a very dedicated dissection. Actually, it's like when you are, this is like kind of a first surgery, then we will not encounter like a kind of the loss of playing. The playing is just nicely,
Yes.
you know, yes,
Yes.
yeah. But the challenging thing is that, for example, it is like previous multiple surgeries.
Yes.
Yes, yeah, all right, when we can lost the plane. And then the second one, like previous radiation. For example, she had it C rectum before. And
Right.
then when we need to do like exenteration, for example, and that's we lost the plane after radiotherapy. And in our side, like endometriosis, even not malignant, not cancer, then there will be have lots of adhesions, and even the pouch of Douglas is obliterated. And so, yeah, these are the challenging things. Yeah.
And indeed they are. And sometimes with redo surgery in the abdomen, particularly those people who've had inflammatory bowel disease and Crohn's, in particular, multiple sections, sometimes the abdomen is just full of adhesions. And I remember my first consultant, Mr. William Walter Frederick Southwood. He was like Zorro with a 22 blade. And his technique was just sublime. But with adhesions, and that is one, you come from normal to abnormal, and you just go gingerly. But sharp dissection is the best thing. And to separate adhesions like that, a blade is better sometimes than scissors. But as you say, endometriosis, radiation, inflammation, cancer, trauma, all of those are actually going to destroy your anatomical plane. And that's where surgery then does become very challenging.
I think in some cases, for example, like a malignancy, and if there is a adhesion, then because of, as you mentioned, tumor invasion, so when there is a tumor invasion, and because we want to get it like tumor-free margin, so like, for example, it's like a wartime hysterectomy, if there is invasion, we might want to go away from the tumor invasion. So it's like we will go beyond that, the tumor invasion, in order to get it the tumor-free surgical margin. So sometimes if really stuck, or then we may not dissect to that, where the adhesions area. And in your the pre-test, and then we'll, it's like using the electrosurgery. So if that, because it's because of this thermal injury, and so for example, it's like ureter, when we dissect to the lateral side in a pararectal space and paravesical space, where you want to look for this uterine artery and ureter. So it's like better we use like what you mentioned before, the sharp dissection or the blunt dissection rather than using this electrosurgery, because there is important structures there, especially the ureter, that we really have to respect. Yeah.
Indeed. And damage to the ureter is definitely a problematic. And when you're in the abdomen and the thorax as well, the thoracic duct, likewise, is extremely important to avoid. And in the supplemental program, as you know, I dissect out the mediastinum. And in the past 2 occasions, I've gone through the posterior mediastinum and dissected out the trachea, the esophagus, and actually found the thoracic duct as well, which is extremely fragile. But if you know your anatomy, you know where to look and where to be careful of it. And certainly a Pledgett or Roberts would be very helpful just to tease out that. But those are very good observations, Prof. Thank you very much indeed. Do we have any questions from anybody else in the audience, please? No, no questions from anybody at all. Okay, well, I'd like to thank Sensei Kedi and Sensei Sile for joining me this evening in the dissection, and thank my son Alistair for helping. Next week, we're going to talk about forceps. We've used them this evening. They have to be used with care. And this is where the feel and the lumbricals come into play. Remember, as we have introduced this as the freestyle sign for photographs at the Black Belt Academy at the University of Malaysia. Everybody who comes on our course, teach them freestyle this. This is 90 degrees and the lumbricals, which brings the fingers together and enables you to feel. Dr. Apogito, thank you very much indeed for being the producer this evening, and thank you, Echo. And please fill in the feedback form. Please pass the word around, and we look forward to seeing you next week. The week after that, we're going to do something slightly different, and we're going to learn about the principles of learning a motor skill. And I have a surprise for you as well. We'll see you next week, and thank you for joining the Black Belt Academy.